there are two fractions of bilirubin. There's the conjugated fraction, the unconjugated fraction. And to understand how these things are synthesized, we looked at just the general metabolism. So we said that most of this bilirubin came from these old erythrocytes that had been broken down. The heme is liberated, it's converted ultimately to bilirubin. Now, this bilirubin produced initially is unconjugated. Unconjugated, it's not very water soluble. It's mostly produced in the spleen. When the spleen's breaking down the RBCs, it has to get to the liver for excretion. To do that, it has to be carried on albumin. Albumin is soluble in the cardiovascular compartment. Bilirubin is not. So bilirubin gets complexed with albumin. Albumin comes down through the blood, enters into the liver, and this bilirubin is transferred to the cytoplasm of the hepatocyte. Now, a fraction of this bilirubin immediately is going to be diverted to the endoplasmic reticulum, in which you find an enzyme called uridine diphosphate glucuronacetyltransferase. It takes this unconjugated bilirubin, which is a very fatty kind of molecule, and it'll conjugate it to glucuronic acid, which is very water soluble. And this creates an amphipathic molecule in which we have a very hydrophilic end and a very hydrophobic end. This amphipathic molecule is capable of forming micelles. The bilirubin ultimately is secreted into the biliary canaliculi, becomes part of the bile. The bile is injected into the duodenal sweep at the ampulla, and all of that conjugated bilirubin, which can form a micelle, can help emulsify fats by breaking it up into micelles. Increases the surface area through which the lipases and phospholipases can act, breaking down the fat. And from there, we said that the bilirubin travels through the small bowel, gets to the terminal ileum. A fraction of it's going to be resorbed, it's going to be returned to the liver. This is called the enterohepatic circulation. And from there, some of the bilirubin is broken down by bacteria, other components of other parts of bilirubin that can be kept intact. The intact bilirubin confers that particular color to the stool. Okay, if the bilirubin were not present in the stool, you have what we would call acholic stool that would look kind of a grayish-white color. Okay, so that was the metabolism of bilirubin, how it's produced. We said that understanding this metabolism of bilirubin would be important to help determine the etiology of jaundice. We do have these two fractions of bilirubin making up the total bilirubin that you find in the blood. We've got the unconjugated fraction, we've got the conjugated fraction. If you want to determine the etiology of hyperbilirubinemia, you first start by determining which fraction of bilirubin is out of proportion to the other. Is the person with jaundice have a predominantly conjugated hyperbilirubinemia or unconjugated hyperbilirubinemia? If you know that, you can determine at least roughly where the disruption in bilirubin metabolism is. So, for example, a person has a predominantly unconjugated hyperbilirubinemia. Okay, something is disrupted the bilirubin metabolism proximal to the endoplasmic reticulum where it's conjugated. If, however, you discover the person has a predominantly conjugated hyperbilirubinemia, then the problem is distal to the conjugation step. Okay, so we were just about to talk about some generalities of how one can consider the etiology of hyperbilirubinemia. Let's, however, first review a few things about the properties of this conjugated and unconjugated bilirubin. Okay, there are some alternative names we need to be aware of. The types of bilirubin, we said unconjugated, conjugated. Let's talk about the unconjugated fraction first. This is also known as the indirect fraction of bilirubin. The word indirect refers to how the concentration is calculated. You have the total bilirubin consisting of the unconjugated fraction plus the conjugated fraction. Okay, if you want to measure the unconjugated bilirubin, it's kind of tough to do, so rather than measure it directly, you measure the total bilirubin, you measure the conjugated fraction of bilirubin, and to get the unconjugated fraction, you simply subtract. Okay, the total minus the conjugated. And so in that respect, you are measuring the unconjugated fraction indirectly. That's why it's called the indirect fraction. All right, so this is a water-insoluble fraction. As a result, if it gets into the bloodstream, it's going to have to be carried by albumin. Albumin, big molecule, 69 kilodaltons, too big to make it through the glomerular filtration barrier. And so if someone has an unconjugated hyperbilirubinemia, that unconjugated fraction is not going to make it into the urine. Because it's being carried by albumin, it can't solubilize, can't be solubilized in the cardiovascular compartment. So if it's traveling through the cardiovascular compartment, it's pretty much stuck on albumin. It doesn't make it through the glomerular filtration barrier, so it's not going to be excreted by the kidney. Okay. Also, because it's very hydrophobic, it likes it to hide into hydrophobic phases, organic phases. And so if the unconjugated fraction increases in the bloodstream, if it has the opportunity, it will diffuse into the lipophilic tissues like the brain. And if it gets into the brain, starts to accumulate, we call that condition kernicterus, jaundice of the brain. The unconjugated fraction disrupts the metabolism of the brain, and it can cause some issues, toxic issues to the brain, particularly in a developing child. The CNS is pretty susceptible to the toxic effects of the unconjugated fraction if it should cause kernicterus. Conjugated fraction is also known as the direct fraction because you measure it directly. You don't have to calculate it, you measure it directly. So it's called the direct fraction. This is a water-soluble fraction. It doesn't have to be carried on albumin if it travels through the cardiovascular compartment. And so it's a molecule small enough on its own to get through the glomerular filtration barrier, and it can be excreted by the kidney. It can be present in the urine. All right, so let's have a look at some of the different things that can happen to the bilirubin metabolism. We laid this out for you, metabolism. Let's take a look at a few examples that might disrupt the conjugated fraction or the unconjugated fraction. And generally, in all these different diseases which cause hyperbilirubinemia, you will find that both the conjugated fraction and the unconjugated fraction will be elevated for the most part. It's a question of which one is elevated out of proportion to the other. That's what you're looking for. Again, you might find both fractions elevated. It's a question of which one is elevated out of proportion. That's how we define a predominantly conjugated or unconjugated hyperbilirubinemia. So let's take a look. How about a hemolytic anemia? A hemolytic anemia could cause jaundice. If that's the case, then there's an accelerated production of bilirubin. The problem is proximal to the conjugation step, and so you would expect that individual to have a predominantly unconjugated hyperbilirubinemia. Okay. Reduced hepatocellular uptake. There are a couple of carriers here that have to transfer this molecule into the cytoplasm. Maybe that carrier is not working, maybe that carrier is blocked by a drug. If that happens, again, the problem is proximal to the conjugation step, so you're going to expect an unconjugated hyperbilirubinemia. Okay, what happens if there's impaired conjugation? So the conjugation step itself is impaired. Maybe due to a enzyme defect, for example, fluctuating levels of enzyme. That's going to present with a predominantly unconjugated hyperbilirubinemia. Decreased hepatocellular secretion, right here, step 4. Okay, well that's distal to the conjugation step. So you're going to build up mostly conjugated hyperbilirubinemia. Impaired bile flow. What if you have a stone stuck over here? Okay, gallstone. Comes out. Where's it going to get lodged? Right here at the ampulla. That's the strictured area. It's going to get caught there. It's going to back up the bile. The bile is going to contain a lot of conjugated bilirubin. Back up that way, you're going to have a conjugated hyperbilirubinemia. Hepatitis. Now you wouldn't guess this one. This one's a little hard based on the mechanics we've been discussing. But a hepatitis results in a predominantly conjugated hyperbilirubinemia. And we already talked about biliary tract obstruction. If you have any kind of obstruction here in the biliary tree, that's distal to the conjugation step.
Dr. Manning,
Yes.
you say hepatitis as an unconjugated?
Hepatitis conjugated
Conjugated.
hyperbilirubinemia. Okay, any questions on that? All right, so we have an understanding of how this works. So let's take a look at some actual diseases. We got an understanding of generalities. Here's some examples of diseases. Physiologic jaundice of the newborn. This is a problem with the activity of UGT. Child might be born with a liver that's not fully expressing enzymes. It's not uncommon. Maybe they're not expressing enough UGT activity, and there's a problem with conjugation. Well, that's going to result in a predominantly unconjugated hyperbilirubinemia, and so sometimes a child born has some jaundice. Usually isn't a problem, but you know the danger of an unconjugated hyperbilirubinemia is kernicterus. Particularly in the developing child, that can be problematic, so we don't take any chances. We want to reduce the level of the unconjugated bilirubin fraction. To do this, we can use UV radiation. Long wave UV radiation will break down the bilirubin. Remember I told you that if some fecal material sits in the sun for a long time, it goes from that brown color to that white color. That's an example of a photolytic reaction. That photolytic reaction is propagated by the UV radiation. You can use that same principle to reduce the unconjugated fraction of bilirubin in a child that has physiologic jaundice. Generally, what you do is you take the child, basically strip the child of everything except eye protection, some genital protection, and you put the child in what looks like a kind of aquarium, and you bombard the child's skin with long wave UV radiation. And of course, the blood going to the skin is going to receive that information. It'll receive all of that bilirubin, and the UV radiation is going to break down the bilirubin into basically byproducts that are water soluble, and the child can just urinate it. And that should be fine to reduce the child's bilirubin levels, at least temporarily, until the child can express fully the amount of enzyme activity they should be expressing. Sometimes physiologic jaundice of the newborn will be exacerbated by breastfeeding. The breast milk has beta-glucuronidases in it, which means that some of the conjugated bilirubin might be broken down back into unconjugated bilirubin. Again, that makes the problem worse, but it's not a reason generally to stop breastfeeding. All we have to do is just increase the frequency of UV radiation treatments. Crigler-Najjar syndrome type 1, that is the result of a complete absence of UGT activity. There is not a good way of treating that. You can't treat that with UV radiation bombardment. There's just too much of an accumulation of unconjugated bilirubin. If something is not done, usually a child will die secondary to kernicterus. And really the only thing that you can do ultimately to treat this is to replace the person's native liver that has no UGT activity with a liver that does. So we have to do a liver transplant for that. Crigler-Najjar syndrome type 2, that is a problem with a partial decrease in UGT activity, and usually, again, this isn't a problem. We can manage the initial threat of toxicity to a child, again, with this UV radiation. Eventually, the child will develop some degree of UGT activity. It won't be enough to keep the bilirubin levels in normal range, but if we can get that person out of the period where they're sensitive to high levels of unconjugated bilirubin, eventually they can go on with their life without too many problems. They'll have discoloration of their skin and their eyes. Their bilirubin levels will be high. But as long as we get them out of that early phase where the brain is susceptible, they are fine. They don't demonstrate really any long-term detrimental effects, as long as they're managed properly initially. Next syndrome you're going to see a lot of. Most people pronounce this Gilbert syndrome, but it's really pronounced Gilbert syndrome. It's a very common defect of the promoter in the gene that encodes for UGT. The gene has a proper encoding region. The enzyme that's produced from that gene is perfect, it works. The problem is in the promoter of the gene. That's the part of the gene that controls the expression of the gene. So there are times when not enough of this enzyme is made. There are other times where enough of this enzyme is made. And so what you see in people with Gilbert syndrome is that they have fluctuating levels of bilirubin. Usually the normal level of bilirubin would be less than 1.2 mg per deciliter. In a person with Gilbert syndrome, you'll find that sometimes it's within normal range, sometimes it'll probably be on the order of 5 mg per deciliter. It's elevated, but at 5, generally it's not going to cause any cosmetic problems. If you look closely at the eye, the sclera of the eye, it might be slightly yellow, but otherwise is okay. Everything with this individual is pretty normal. The only problem with Gilbert syndrome is it presents you with this clinical curiosity of why the person's bilirubin levels are fluctuating all the time. Sometimes they're in normal range, sometimes they're a little high. Your guess would be Gilbert syndrome. You don't work it up any farther than that. As long as it's within reasonable range and it's not causing other problems, you just let that go. But this is a condition generally that affects almost 10% of the population. So chances are a few of you in this room actually have Gilbert syndrome. Okay, so the workup. So again, you're going to be measuring the total, the direct bilirubin fraction. The lab is going to calculate the indirect fraction for you. There are going to be different procedures and workups, of course, depending upon whether the conjugated fraction's out of proportion or the unconjugated fraction's out of proportion. So if the indirect fraction's out of proportion, you're going to check things most likely that develop proximal to the conjugation step. So a common problem is maybe some sort of hemolytic anemia, so you're going to get a CBC, blood smear. That would make sense. It wouldn't make a whole lot of sense to do that if the direct bilirubin fraction were elevated, conjugated fraction were elevated, because this is most likely a problem distal for the conjugation step. So maybe there's a problem with the liver, might get liver function tests. Okay, a HIDUS scan is a hepatobiliary aminodiacetic acid scan. It's a scintillation scan, type of nuclear scan. We use it basically to assess the patency of the entire biliary tree. So maybe there's a stone here. We can see that with a HIDUS scan. So maybe that would be worth doing again in the right context. So that would make sense again if you had a elevated direct fraction. Any questions on that? Yeah.
What is this word that you mentioned a couple of times? Kernicterus?
Kernicterus. That's icterus of the brain. Icterus meaning jaundice. Kernicterus refers to jaundice of the brain.
Thank you.
Anything else? Okay. So let's look at different types of liver failure. So based on the morphology of the liver at the time of failure, we can subclassify liver failure into three categories. Liver failure due to massive hepatic necrosis, liver failure due to chronic liver disease, and liver failure due to hepatic dysfunction without necrosis. So massive hepatic necrosis, pretty much self-explanatory. Something causes more than 70 or 80% of the liver to necrose. The liver doesn't have sufficient mass to perform any normal function that the liver should be doing. So a couple of things can be responsible for this. Fulminant viral hepatitis. The word fulminant just means unstable, rapidly progressive. Some people who contract the hepatitis virus, for example, will develop a chronic inflammation of the liver. Other people develop some very acute degeneration of the liver. It doesn't happen often, but it happens in some individuals. Even something relatively benign as hepatitis A in certain individuals can cause massive destruction of the liver. Most of us get hepatitis A, we'll have GI symptoms, we'll develop jaundice, eventually we'll get an immunity to hepatitis A, and you'll be immune for the rest of your life. Others develop this fulminant viral hepatitis that causes degeneration. Other things can do drugs. Certain individuals, especially if certain drugs are used in combination, alcohol and acetaminophen, a very common combination that can cause trouble in some individuals. Palathine is a general anesthetic. Tuberculin drugs, I've always said tuberculin drugs are hepatotoxic. People that are on them feel miserable. And monoamine oxidase inhibitors, which are antidepressants, sometimes those can cause trouble in certain individuals. The main difference in the way individuals handle these drugs is their cytochrome P450 profile. Have you talked about that in some of your other classes? Cytochrome P450 is a large family of enzymes that catalyze reactions in your liver. They mostly catalyze redox reactions. They determine predominantly the way in which you as an individual will metabolize a specific drug. Most of us will metabolize a drug in a similar way. Others have a very dramatically different way of metabolizing. And so sometimes an unusual pathway will result in unusually toxic things produced in the liver that can cause degeneration. Chronic liver disease. Okay, that includes things like cirrhosis. When we say cirrhosis, we mean scarring of the liver. We're going to address that in a minute. That's an example of chronic liver disease. And then we've got hepatic dysfunction without necrosis. For example, hepatic steatosis, which means fatty liver. That can develop for one of many reasons, but sometimes the liver is so fatty that it just doesn't function well. Even though the hepatocytes aren't necessarily necrotic, there's so much fat in the liver, the hepatocytes just can't perform their normal functions. So here's an example of fatty liver change. Normal liver, central vein, there's the portal triad. Again, you can see the hepatic organs all separated by the sinusoids. So blood trickles down here from the portal, the hepatic portal triad down to the central vein. The hepatocytes operate on the blood, taking nutrients, making proteins. Everything works fine. This is the normal architecture. Over here you can see for comparison of fatty liver. This is what we call a steatotic liver or hepatic steatosis. Again, you got the portal triad, central vein. You can see that a lot of these hepatocytes are fatty. Take a closer look at it. Portal triad, central vein, and you can see these hepatocytes here that have a large unstaining material in their cytoplasms, and that's all fat. That's a fatty liver. I think you can appreciate just how distorted the hepatocytes are. Not too much of a big step to think how that's going to interfere with the liver's function. You can see hepatic steatosis on the CT scan. You can appreciate just how distorted the liver becomes when it's filled with fat. It becomes quite large. Okay. Here's a CT scan of a normal liver. So we've got anterior, posterior. There's right, there's left. And again, you can see we've got kidneys over here. There's the spleen. There's the descending aorta. That's the inferior vena cava. Over here, you can see the liver very clearly. There's the gallbladder. If you look at the normal liver here, you'll notice that the right lobe of the liver is more radiodense than the left lobe of the liver here is more radiodense than the right lobe of the liver here. I think you can appreciate that even with a crude CT like this. That's because there's more fat normally in the right lobe. That's normal. So it's normal to see this radiodensity disparity. Okay? That's really exaggerated when you see a steatotic liver. So this is a CT scan of the steatotic liver. This whole thing is the liver. You can see how big it is compared to normal. You'll also notice the radiodensity. It's very radiolucent. And that's because fat is more radiolucent. This liver is infiltrated with fat. And it's distorting the size, and it's reducing the radiodensity substantially. Okay, any questions on that?
Dr. Madden?
Yes.
So hepatic steatosis is a chronic hepatic dysfunction without necrosis, or is it like a chronic liver disease?
Yeah, I would classify it as dysfunction without necrosis. The condition could progress to something chronic like cirrhosis. A liver like this you might find in an alcoholic. Not all alcoholics develop liver cirrhosis, but they do develop steatosis like this. Okay, so let's take a look at a specific example of hepatic failure. we're looking at chronic liver disease, and of course, one form of chronic liver disease is scarring of the liver, also known as liver cirrhosis. So there are many etiologies of liver cirrhosis. All of you know the most common one being alcoholism. It accounts for up to 70% of all the scarred livers. Then we have various forms of viral hepatitis, accounting for up to 10%. That includes hepatitis B, hepatitis C. Most of those are going to be caused by hepatitis C. Biliary diseases, meaning the biliary tracts causing some sort of obstruction. Okay, again up to 10%. Hemochromatosis, the iron storage disorder. Okay, this is the disease caused by a defect in the gene. Which one's the gene? Easy to remember. Those are the redox enzymes. This is a iron carrier. What gene? The high iron gene.
Yeah, which
That's
is
the one.
FE.
Easy to remember. Wilson's disease, what's that? Again, another storage disorder. Accumulation of copper. That's Wilson's disease. So problem with the gene encoding for ceruloplasmin. And you know about the alpha-1 antitrypsin deficiency. Alpha-1 antitrypsin, that's an anti-elastase. Some forms of this deficiency will cause liver cirrhosis, others will not. All of those deficiencies will cause premature emphysema. A subset of these types of deficiencies also cause liver cirrhosis. That's because this protein is synthesized in the liver. Some forms of deficiency, the enzyme never gets synthesized. Other forms, the enzyme gets synthesized, but it's not exported from the liver, and it remains in the hepatocyte. Those are the forms that cause liver cirrhosis. And then everything else, you can't determine the etiology. It falls into this waste paper basket diagnosis. It's called cryptogenic cirrhosis. We don't know why the person's developing liver cirrhosis. Okay, so let's take a look at some other let's take a look at the pathogenesis of liver cirrhosis. So I'm going to show you this in detail in a minute, but in some individuals, liver cirrhosis develops as a consequence, for example, of alcoholism, while in others it does not. About 1/3 of alcoholics actually develop liver cirrhosis. So what's the difference? Generally, liver cirrhosis, liver scarring, is caused by chronic inflammation of some kind. There's some sort of chronic inflammation. People respond to that chronic inflammation differently. Some people have an appropriate repair mechanism that responds to the chronic inflammation. Others have an inappropriate repair mechanism. Those that have an inappropriate repair mechanism, there is a cell that's normally found in the space of discs. It's called the ETO cell. It is a vitamin A storage cell. And sometimes this cell, under conditions where it encounters chronic inflammation, differentiates into a myofibroblast, and it starts elaborating collagen. And that's what causes the liver to scar down. Usually, the antecedent condition has to be chronic inflammation. Any one of these diseases, you can see, will cause chronic inflammation. The liver, you get a steatotic hepatitis. This, of course, is a viral hepatitis. Biliary disease, that causes a hepatitis. Genetic hemochromatosis, the iron that accumulates in the liver will catalyze a inflammatory reaction. Same thing's true for Wilson's disease. Okay? It's true for just about everyone. It's true for everyone. Okay. Yes.
What's the name of the cell one more time? Sorry.
What?
The cell that did the
ETO cell. it's on page, I think, 36. Major source of collagen.
Oh, sorry, thank you.
So we have several problems that develop. Person's cirrhotic liver, it's scarred down. Blood, particularly from the portal vein, can't flow through it properly because the architecture is disrupted and the resistance to blood flow is high. So naturally, you develop portal venous hypertension. There are some other issues that develop because the liver cannot properly filter the blood. So things like jaundice will develop. Okay? The liver synthesizes albumin. Problems with the liver usually result in hypoalbuminemia. In fact, albumin is a marker for liver functionality. The liver also is the main site for the urea cycle to operate. It has all of the enzymes for the urea cycle. The urea cycle is used to package nitrogenous waste, for example, ammonia. You gotta get rid of the ammonia. Ammonia is toxic, and so the urea cycle incorporates the nitrogenous waste within the molecular structure of urea, and then the kidney eliminates the urea. But the liver has to package the nitrogenous waste in the urea in the first place. So if people develop a problem with the urea cycle, they develop a hyperammonemia. So just to clarify, let's just, and we got the liver here, we got the kidneys over here. Okay, we start off with this nitrogenous waste, usually in the form of ammonia, some form of it. It goes to the liver. The urea cycle will package it in the form of urea. And then the liver is supposed to get rid of the urea in the urine. So if the liver's not functioning, this can never be packaged. And so ammonia builds up. Whereas if the kidneys fail, you can't get rid of the urea, so blood urea nitrogen increases. Okay, and that results in hyperammonemia. Hyperammonemia itself has a variety of signs and symptoms. As I said, this is very toxic, so people develop encephalopathies as a result of the hyperammonemia. They become confused. The hyperammonemia tends to disable the upper motor neurons, which primarily confer inhibitory influence to the lower motor neurons. And so people with hyperammonemia develop spastic reflexes. So if you were to test the reflexes on individuals, they'd be hyperreflexive. They develop kind of jerky movements as a result of the hyperreflexia. We call that asterixis. They can't metabolize certain substances like, for example, methionine properly. Methionine gets converted to mercaptins by bacteria in the GI tract. These mercaptins are very aromatic, they have a strong odor. If the liver's not working properly, the mercaptins build up in the bloodstream, and it confers what is often described as a musty odor to an individual with liver failure. We call that fetor hepaticus. It's kind of a potent odor. Anyone ever worked with mercaptoethanol? No? Okay. The estrogen levels. Everybody produces estrogen. Most of the estrogen is metabolized in the liver. If the liver's not working, people develop hyperestrogenemia, both women and men. The problems of hyperammonemia are more apparent in men. They can develop things like gynecomastia, breast tissue develops. Also, most individuals will develop a streak of erythema across the palm of the hands. That's called palmar erythema. The inflammation causes scarring, and they develop contracture of their digits like this. That's called Dupuytren's contracture. You can even look at the palms, and you'll actually feel the scar tissue develop. Other things driven by the hyperestrogenemia, these odd cutaneous vascular lesions develop. They're called spider angiomata. Spider angiomata. That's Dupuytren's contracture. Spider angiomata. You've got these vascular lesions on the surface of the skin. It consists of a centrally dilated arteriole from which these little tributaries originate. These are specifically caused by things like high levels of estrogen. You can see them in people with liver failure. You can actually see them in any hyperestrogenic state. You can see them in pregnancy, which is a hyperestrogenic state. This is what they actually look like. And you can see the central arteriole and the little tributaries. Okay, multiple organ failure. So the liver fails, it's not processing a lot of toxins, so you're going to get other systems fail, especially the respiratory system. People are more prone to pneumonias. The kidneys also don't function well. The glomerular filtration rate decreases. Not really clear what the interaction is. There's no primary problem with the kidneys, but it seems the liver doesn't metabolize something, and this something causes vasoconstriction of the afferent arterioles, and that reduces the glomerular filtration rate of the kidneys. So the kidneys appear not to be working. Even though there's nothing physically wrong with the kidneys, this is a secondary effect. The kidneys simply are responding to some sort of vasoconstriction. Okay, so let's have a look. A couple more things. Coagulopathies. So the liver, of course, is making coagulation proteins, and if someone's not making those coagulation proteins because of liver disease, they develop a bleeding diagnosis. And we already talked about hepatic encephalopathy. Hepatic encephalopathy could result in an increase in or levels of pneumonia resulting from hyperammonemia. It can be a pretty quick change. Usually, to prevent this from happening in a person with liver failure, we put the person on a protein-restricted diet. Most of the ammonia comes from our dietary protein. Most of the time they do well on this. They stay to the diet. But as a result of the coagulopathy they develop, sometimes they will bleed into their own GI tract. That bleed delivers numerous plasma proteins to the GI tract, and they start digesting their own proteins, and that liberates a lot of ammonia. So sometimes they suddenly develop an encephalopathy, hepatic encephalopathy. If that's the case, they haven't eaten protein that they're aware of, you might suspect the GI bleeding. Okay, we talked about the hyperreflexia. They also are very rigid for the same reason. Seizures, asterixis refers to that clonic movement. They kind of get that jerky movement as a result of the hyperreflexia. Okay, let's take a look at a cirrhotic liver. We'll take a break. This is what a cirrhotic liver looks like. And you can see the surface of the liver here. You'll notice it's remarkable for all of these little nodules. Those nodules are actually areas where there are normal hepatocytes. In between the nodules, you can see these little troughs. Those are areas that are populated with lots of fibrous tissue. It's the fibrous tissue coming from the Ito cells. And so this fibrous tissue is generated, kind of breaks up the liver into these isolated nodules of normal hepatocytes. You take a section through this liver, you can see this close up here, again, lots of nodules and the nodular liver. You take a section through those nodules, you can see the scarring. This is a trichrome stain, the Mazan trichrome stain, you recall, that shows you the scar tissue in blue. So you have these isolated pockets of normal hepatocytes separated by these large bands of scar tissue. Okay? This would appear as a nodule, that would appear as a trough. And the last thing before we take a break, here is a summary of some of the different problems associated with liver cirrhosis, specifically this form of liver failure, hepatic encephalopathy due to the high ammonia levels, spider angiomata due to the high estrogen levels, esophageal varices due to the portal venous hypertension. The spleen is enlarged because the portal vein, which is right here, communicates with the splenic vein, so blood backs up into the spleen, you get splenomegaly. The veins around the umbilicus also communicate with this system, so they too become engorged. And so sometimes this is called the head of Medusa. Hemorrhoids, same thing. Testicular atrophy due to the high levels of estrogen, they'll antagonize the androgens. The portal vein has a high pressure, and that sometimes will cause high hydrostatic pressure in the liver to produce a transudative effusion that accumulates in the peritoneal cavity. We call that, of course, ascites. Initially, it's transudative. The biggest problem with this ascites is that sometimes bacteria from the GI tract will colonize the fluid, resulting in a spontaneous bacterial peritonitis. So a septicemia can develop just because there's fluid in the peritoneal cavity, and the bacteria just love to get into that. Okay? All right, we'll take a look at the rest of this after the break.